Good evening, everybody, and welcome to our national seminar for younger people living with myeloma. We're really excited to be here. My name is Kath Bowley, and I'm one of the specialist myeloma nurses from New South Wales, and I'm co-chairing the seminar tonight with my fabulous colleague, Narelle Smith, who is our senior specialist myeloma nurse in WA. We'd like to begin by acknowledging the traditional custodians of country that we are all meeting on throughout Australia this evening. We acknowledge their continuing connections to land, sea, and community. We pay our respects to their elders past, present, and emerging, and we extend that respect to all Aboriginal and Torres Strait Islander people watching with us this evening. I'm here on the central coast of New South Wales on Darkinjung country. Tonight's seminar is themed Young and Strong, Thriving with Myeloma, and our seminar aims to empower younger people living with myeloma. This seminar has come about as a result of the emerging themes that we discovered when we surveyed our younger persons community last year. This seminar would not be possible without the support of the Global Myeloma Action Network, who have provided us with funding to be able to present to you this evening. We have three wonderful speakers lined up for you tonight, and the seminar will run for approximately 90 minutes. You can submit any questions during the seminar via the Q&A box if you scroll down the page, or via the live chat box, which is available by tapping the three dots in the top right corner of your screen. We will do our very best to respond to your questions tonight, but please include your email so that we can respond that way if required. You could also email any unanswered questions directly to our nurses inbox, nurses@myeloma.org.au. If you are experiencing any technical difficulties this evening, you please call 0447 332 294. A reminder, this seminar will be recorded and available for playback on our website. We are really passionate about this group and your unique needs, and we do not want this to be a one-off seminar. We would love to know what you think. Your feedback is really appreciated so that we can tailor future events to meet your needs. You will find an evaluation survey link at the bottom of this webpage, so please complete that at the end of the seminar. To start this evening, it is my pleasure to introduce Dr. Hasib Siddiqui. Dr. Siddiqui is a consultant haematologist at Fiona Stanley Hospital, and he specialises in myeloma and amyloidosis, with a particular interest in transplant and immunotherapy and CAR T cell therapy. He is a graduate from Royal Perth Hospital and Sir Charles Gardner Hospital, and returned to Australia from a fellowship at the Mayo Clinic in Rochester, Minnesota in 2019. Dr. Siddiqui is going to talk to us this evening about late effects and toxicities of treatments. Thank you, Dr. Siddiqui.
Thank you so much, Catherine, for the introduction. Sorry, I think we may have had a slight difficulty with IT issues, but we're back on song. So let's get cracking. I just wanted to thank Myeloma Australia for the invitation to speak at this event. I think the key points to make are that anytime we are talking about late effects and toxicities of treatment for a malignant condition, it's always a good sign. It means that we're actually making some progress in treating that condition. And whilst thankfully myeloma in a younger population is not that common, we do still have a significant patient group that are diagnosed with myeloma at a very young age. Some of the younger patients that I have treated have been diagnosed in their 20s. And so this is particularly relevant for a significant proportion of our patients. So to get things started, I think just a bit of an introduction into myeloma, which you are all very familiar with. It's a cancer of the plasma cells, which live in our bone marrow. And there's about 2,000 new cases in Australia per year. It accounts for about 1.5% of all cancers. So certainly not as common as some of the more common malignancies like breast cancer and bowel cancer and so on, but a significant proportion of people are living with this disease in Australia. As you all know, it can cause a number of problems, that classic sort of crab phenomena that we talk about where your calcium goes up. It can damage the kidneys, cause bone marrow failure and anemia, and those nasty bone lesions that can be the source of significant symptoms. Although it is an incurable malignancy, it is extremely treatable, and that has significantly moved forward over the last couple of decades. So these are a couple of studies that have looked at improvements in myeloma outcomes over time. And what you will see in the first figure, which is comparing patients with multiple myeloma versus a control group or a control cohort, that over the last 2 decades, the survival outcomes have steadily improved every sort of 5 to 10 years. Now, there's still obviously a significant gap compared to the average person that's matched for age and sex, but things are improving, and that's really heartening to see. And if you look at the curve on the right, the curves on the right, those graphs look at survival improvement in outcomes according to age group. And what you will see is that the improvements tend to be more significant in the younger population. That may be a reflection of better tolerability of some of the newer treatments that we have. But overall, these curves are really encouraging and promising in terms of us really shifting this from a malignant disorder that really limits survival to something hopefully that is transitioning to a chronic disease that we can manage over time. And the main reason for that improvement is improved therapies. So this graphic just gives us an indication of some of the milestone moments in myeloma therapies. And what you notice is that, the last 2 decades, from the year 2000 onwards, we've really had a plethora of novel agents, these new drugs that work in novel ways to get rid of these malignant plasma cells. And really, I think, the current decade is really the decade of immunotherapy. And I think it's going to be fascinating to see how much that those survival curves improve over the next 10 to 15 years. So let's just talk a little bit about treatment pathways, because I think this really gives you an indication of, some of the late effects and toxicities that patients are likely to experience. I like to think of myeloma treatment as 3 sort of separate categories separated in time. So I break it down into an induction phase, a consolidation phase, and a maintenance phase. And if you're kind of looking at timelines, usually the induction phase, we're looking at the sort of first 4 to 6 months of therapy. The consolidation phase, which we'll talk about a little bit, usually, you're looking at about 2 to 4 months of therapy. And then the maintenance phase really is indefinite. And that's something that we've learnt with time, that, longer duration of therapy leads to better outcomes. And at diagnosis, we have this separation of people being transplant eligible, so able to receive a stem cell transplant or not. And, some of the factors that go into that are age and other medical comorbidities. A stem cell transplant is a very intensive treatment, and we'll talk about some of the later effects or late toxicities of a stem cell transplant. But nevertheless, if you're young and transplant eligible, ordinarily you would have induction chemotherapy with 3 medications, bortezomib, lenalidomide, and dexamethasone. That will go on for somewhere between 4 to 6 cycles, and then proceed to a stem cell transplant, which is really the consolidation phase of that pathway. Following a stem cell transplant, you generally go on to single agent maintenance lenalidomide. For patients that do not receive a transplant, the induction is very similar, although there is some variability depending on whether you're able to tolerate some of these medications. But nevertheless, it will usually involve 3 chemotherapy agents or 2 chemotherapy agents for a period of 6 to 8 months, followed by a maintenance phase, which usually involves 2 drugs. Generally, lenalidomide and dexamethasone are the medications that we use in Australia, but nevertheless, you continue that treatment until the disease progresses. And what are the goals of these different phases of therapy? Well, I like to think of the induction phase as you are trying to rapidly control the myeloma and the damage that it has caused. The consolidation phase is like a bit of a sledgehammer. You're trying to induce remission and hit it on its head. And that's what the stem cell transplant is really all about. And then the maintenance phase is really maintaining that remission if you're able to achieve it. and preventing relapse. So even if you don't achieve a complete remission, the idea is, well, let's control it and make sure that it doesn't relapse. And I think, this gives you an indication that, treatment often, continues for a long period of time, and that can have significant toxicities and side effects that go along with it that you need to be aware of. And this is a very typical representation of what happens with multiple myeloma. Oh, excuse me, I don't know what's happened there, but there we go. So this is a very typical representation of what happens with multiple myeloma, in that often a patient is diagnosed, we give them first-line therapy with that goal of achieving a remission, and hopefully that goes on for as long as possible. But unfortunately, because it is an incurable cancer, it will relapse at some point and often require a second-line therapy, which will hopefully control it for a period of time. But it's not uncommon for relapses to occur over time. And one of the things we find is that, unfortunately, the disease does become a bit more aggressive as we progress. But over these periods of time, you will find that, there are different chemotherapy drugs that you're on for different durations, all that have, some unique side effects that you may or may not experience. And I think, it's important to be aware of these things, because really quality of life is a big part of treating this condition now. If we're really shifting the needle towards treating this like a chronic disease, we need to ensure that people are living good lives, not just longer lives. So the toxicities of treatment, as I mentioned, I think, patients are on treatment for longer nowadays. You're likely to undergo more numbers of lines of therapy. Some of these new drugs that we talked about that have been, developed over the last decade or two have unique side effects that you need to be aware of. And what we know is that the cumulative rate of late toxicities increases once you've been on treatment for longer. This can impact your quality of life and the ability to treat the myeloma. Ultimately, you want to try and control it as best you can. And if you're experiencing significant side effects and are not able to keep patients on treatment, that can affect the ability to control it. So monitoring and management of these side effects is important. So what are the different side effects that you can experience? Well, there are a number of different agents that we use to treat multiple myeloma, and all of these have either unique or overlapping side effects. And what you can see here, this representation just shows you that literally any organ system can be affected when it comes to some of these drugs that we use. Now, you will see some common names there. Bortezomib, for example, a very common drug that we use for multiple myeloma, notorious for causing peripheral neuropathy in some patients, but can also be associated with some ocular symptoms, some gastrointestinal side effects, and so on. But then there's some overlap as well. So peripheral neuropathy is not just associated with bortezomib. There are other medications such as thalidomide, less commonly drugs like carfilzomib or lenalidomide or pomalidomide. But there are other drugs that can also cause peripheral neuropathy. And if you've had one agent at a period of time and developed some side effects, in the future, if you're treated with a second agent, it may also affect that particular toxicity. So the first sort of category of late effects that I really want to talk about is late effects of autologous stem cell transplantation. I think for a younger population, this will be standard of care therapy for most patients. Most patients are going to be transplant eligible. That's not to say that everyone absolutely has to have a stem cell transplant to control myeloma. And that's part of, I guess, the improvements in our ability to control and treat this condition, where we now have good data to suggest that, sometimes you can get away without doing a stem cell transplant and still control the myeloma effectively. But in terms of toxicities, a stem cell transplant can really affect any organ system. There are some unique side effects that you're at risk for with a stem cell transplant compared to having some of these novel agents such as the proteasome inhibitors, bortezomib, lenalidomide, or dexamethasone. And I'd like to discuss some of those things. The first thing to really talk about is your immune system. This is a question that I get often. As you all know, the stem cell transplant, you have this period of time where really you don't have a functioning immune system. You get a high dose of chemotherapy that wipes out your bone marrow, and we try and then rescue that with the stem cell infusion. So there is that initial 2-week period, really, where you really don't have a functioning immune system. Your neutrophil count is often very low, and that's the highest risk period in terms of bacterial infections. And bacterial infections are the thing that we get most worried about. Within that first 2 to 3 weeks, you usually engraft, and those neutrophil numbers start to go up. And then, we all kind of breathe a sigh of relief and say, okay, you've got, white cells that can help you fight infections, and we think you're safe enough to kind of be managed out in the community. But what this graphic shows you is that, even though you've engrafted, so you can see there that engraftment happens between that day 14 to day 28 mark, there are a host of other immune cells that reconstitute slowly over time. And this can take over a year for some people. So you have these other immune cells, such as your natural killer cells, your T cells, and your B cells that are very important in fighting viruses, developing immune responses that take a long time to improve. And so, your immune system isn't like the average person's walking around, despite the fact that you've engrafted and your neutrophils have recovered. And so it's still important to be aware of that. To be sensible, and obviously immune recovery and immune system and infections are very topical, or have been for the last 2 or 3 years with COVID. But it's important to be aware of that, particularly those first few months as some of these other cells in your immune system are slowly building up. So those infective risks change with time. Whilst at the beginning, you are more at risk of bacterial infections, later on, whilst you're waiting for some of these other immune cells to recover, you might be more at risk of viruses. And some of the other immune proteins that you have, such as your immunoglobulins, are also affected by myeloma, and they can take some time to recover. I think the key point I want to make here is that always remember your post-transplant vaccinations. So remember, all your baby vaccines are gone with this procedure, and you need to be revaccinated. And usually most stem cell transplant units will have a revaccination program, whether that's through the actual unit or your GP. They'll provide you with those details on when to start getting those vaccines done. And it's important to not miss those and make sure you complete the full schedule of vaccinations to ensure you're protected. COVID revaccination. So yes, you unfortunately will lose all the vaccines that you've had for COVID when you receive a stem cell transplant. Our general recommendation at this point is to restart that vaccination program at least 3 months after your transplant, because we think, then you have a good chance of having a good immune response to those vaccines. So the next thing I really wanted to talk about are secondary cancers. And, this is really, I guess, one of the things that we see with, people living longer with myeloma who have had a stem cell transplant and have been on different chemotherapy agents over time. What we know is that the incidence rates of secondary cancers for patients who have been taking lenalidomide maintenance over a 10-year period can range from anywhere between 10 to 15%. Fortunately, many of those are just simple non-melanomatous skin cancers, but nevertheless, there are a significant proportion of people that will develop secondary blood cancers. And one of the things that we get, quite worried about is myelodysplastic syndrome or secondary leukemias. Thankfully, the rates of those are quite low, but nevertheless, your hematologist will be looking at your blood counts and making sure that there isn't anything suggestive of that. I think age-appropriate cancer screening is extremely important. So, for the women, make sure you're getting the mammograms and your pap smears, and all of those are up to date. Prostate screening, bowel cancer screening. All of that sort of age-appropriate cancer screening is extremely important, and it's good to have a really good GP that keeps tabs on those things. I generally recommend yearly skin checks for any of my patients who've had a stem cell transplant. And that's not to say that can change over time. I have some patients who need 6 monthly skin checks because, they've had a long history of sun exposure and have had a history of having skin cancers that need to be treated every now and then. So sun safety is extremely important, and I think something that you need to be aware of. Sexual health and fertility. Now, this is a very busy slide. I'm not going to read it all, but I think, this is taken from the BMT Infonet. And what I really want to highlight here is that, this is a significant issue for both men and women who've had a stem cell transplant and who are on chemotherapy over time. We know that chemotherapy can affect, sexual health and fertility for both men and women. Chemotherapy has a significant effect on ovaries. It's associated with premature ovarian failure in women. It can significantly affect the testosterone levels in men. And so, these are common complaints that we hear in terms of, decreased interest or low libido post a stem cell transplant whilst you're on chemotherapy. This can be associated with significant anxiety and present with a significant sort of psychosocial effect on patients. And so I think, it's really important to be aware of this. There are lots of treatments available: hormonal replacement therapy, testosterone replacement therapy, medications that can help with erectile dysfunction, and so on. And so really the key thing is to ensure that you work with your local GP and your hematologist in addressing any of these issues that can become a bit more significant the longer you are on chemotherapy. In terms of fertility, I do really want to mention this, and really the key thing here is that gonadal dysfunction post a stem cell transplant is high. And so the rates of infertility post stem cell transplant is high, and really the time to address this is before chemotherapy and before you actually have a stem cell transplant. And look, there are a number of options that you can look into. For males, there's sperm cryopreservation. For females, there's a number of different approaches that you can undertake. There's the option of ovarian suppression with hormones that can help prevent the damage that chemotherapy can have on the ovaries, but then you can freeze eggs or embryos or even ovarian tissue. And so again, if you haven't had children or you plan on having children in the future, I think you really need to sort of be on the front foot with this prior to the stem cell transplant. Okay, so changing tact a little bit now in terms of moving to some of the other toxicities that we see with other chemotherapy agents. I think peripheral neuropathy with myeloma drugs is a really common side effect that patients experience. Bortezomib is probably the most notorious for causing it. And we've learned over time how to manage this a little bit better. So, bortezomib was a medication we used to give intravenously and almost always used to give it twice a week. And what we found is that a couple of things can reduce the rates of peripheral neuropathy, and these may be suitable. Firstly, we now give it subcutaneous almost universally, and we know that the rates of peripheral neuropathy drop by about a third just by giving it subcutaneously instead of intravenously. And secondly, using the weekly schedule instead of the twice weekly schedule. So there are things that you can do or your hematologist can do to try and help minimize the development of peripheral neuropathy. But as you can see, there are a number of other drugs that, you may be exposed to over time that are also associated with peripheral neuropathy. So what is peripheral neuropathy? It's damage to the nerves that can present in a number of ways. If it affects the sensory nerves, typically you have disruption of sensation, but can be associated with numbness, tingling, paresthesias, or severe burning pain. If it affects the motor nerves, it can cause muscle weakness and wasting. And one of the things that we don't uncommonly see is effect on the autonomic nerves. So, these are the things that help maintain functions like our digestion, urination, defecation, blood pressure control, and so on. And so this can have significant effects on your gut health, significant effects on, some of these postural symptoms that people experience with dizziness and so on. So, it can manifest in a number of ways. The treatment of peripheral neuropathy is multimodal. I think, symptomatic neuropathic pain can be very difficult to treat. And really what I'm trying to highlight here is that there are a number of different components to ensuring you're able to manage this, even if we can't make it go away completely. And so, there are a number of, I guess, complementary treatments outside of just medical interventions or pharmacological interventions that are going to be important in helping you manage peripheral neuropathy. There are limitations to what medications can do. Medications are not a cure. There are no cures for peripheral neuropathy that we can induce with drugs. Really, the goal here is to try and reduce the pain levels so that you can live better lives with your symptoms. And really, medications alone are not sufficient to obtain the best quality of life. They're really an adjunct to lifestyle and psychological changes to ensure you're able to live with some of these symptoms that can often be quite debilitating. There are common drugs that we would use to try and treat neuropathic pain. NDEP or amitriptyline is a common one, as well as some, neuropathic pain agents like pregabalin and gabapentin. These are common ones that anyone who's experienced peripheral neuropathy may have been on. But like I said, there really aren't cures. Opioids really don't work well for peripheral neuropathy. They have very limited benefit and really are reserved for sort of third-line agents to try and treat this condition. Something that works occasionally for patients, particularly those that get sort of patchy sort of peripheral neuropathic pain, particularly in the soles of the feet, that's limited to sort of nighttime neuropathy. There are some of these topical creams that are made with a combination of local anesthetics. Sometimes they also include some of these neuropathic pain medications such as NDEP or pregabalin and so on. These can help, particularly for that neuropathic pain overnight, but most of the time they're not that great to use during the course of the day when you're up and about and trying to get on with your work. Okay. Cardiovascular issues. So, heart issues are really important. They're probably the most notorious drug for causing cardiac problems is carfilzomib, which is a next generational bigger brother to bortezomib that's given intravenously. We know that it can affect the heart, but really, cardiovascular health probably takes a couple of steps before that to manage. Really, there are a number of sort of traditional cardiac risk factors that we look at. Do you have a family history of heart disease? Do you have a history of high blood pressure, high lipids, diabetes, smoking? These are all things that are going to increase your risk of running into heart issues over the course of your treatment. And so it's important to be aware of those and ensure you're managing those appropriately. And I'm going to talk, when it comes to heart issues, one of the ways obviously, we want to ensure you don't run into problems with heart attacks and so on. But another way that heart issues can often manifest is, just profound fatigue and shortness of breath. And fatigue is just a common symptom that you're going to experience with a lot of these drugs outside of running into heart issues. And it's not an easy symptom to treat. It's often not an easy symptom to quantitate. And so, I think often patients can feel quite frustrated that, you keep mentioning fatigue as a side effect, and often we have very limited answers to that toxicity. But I think there are a number of sort of practical lifestyle modifications, things like daily exercise, relaxation, meditation. Those are the kinds of things that are really going to help with fatigue. And exercise, is vitally important. And the important thing with exercise is to try and get it just right. And so you don't want to be doing too much, but you don't want to be doing too little. And it's one of these things where, pacing yourself and slowly building up is really important. And I always recommend a combination of aerobic and resistance exercises. So, the aerobic exercises can start off as simple as a simple 20 to 30-minute walk 2 or 3 times a week, and particularly when you've undergone very intensive treatment, that kind of aerobic exercise training can take time to build. So what I would say is, focus on building slowly over time. Set yourself some simple, small goals, and as you tick them off, build upon that. And really, exercise is going to help from a number of perspectives. A lot of these late toxicities that you experience, some of the psychosocial aspects of managing peripheral neuropathy, for example, exercise is an extremely important part of that. So how do we manage some of these cardiovascular risk factors that we mentioned? So diet and exercise, simple things we've kind of talked about, but it's really important that, again, I highlight this, we're a team looking after you. It's not just the hematologist, it's the allied health professionals, but also your GP, making sure that we're monitoring things like your blood pressure, blood sugar, your kidney function, your cholesterol levels. And there will be medical interventions that you may need to start to, optimize some of those. So it's not uncommon that our patients need to be on diabetes medication because they've been on steroids for a long time, or need to be on blood pressure medications, or, anti-cholesterol drugs. And there will be specialist referrals that will be made when appropriate. So, you might find you need to see a cardiologist or an endocrinologist or an nephrologist. So the next thing I know, and I know time is somewhat limited, but I do want to touch on skeletal-related events. So bone problems, or these lytic lesions that we talk about, these are extremely common in multiple myeloma. About 20 to 30% of people will have these lesions at diagnosis. They can manifest in a number of ways. So, the first picture there, you see these little sort of punched out spots in the vertebral bones. That's that common way that those lytic lesions can present. In the second picture, you really have a myeloma sort of mass coming out of one of the vertebrae and pushing onto the cord, and that can cause significant problems. And then you can have these sort of crush fractures in the vertebra. So the vertebra become weak, and that vertebra can sort of crush, and the height of the vertebra is lost, and that can cause significant pain for patients. And there are a number of things we do to try and prevent those problems. So, calcium and vitamin D, supplementation is a must. But really what we do to try and reduce those problems are bisphosphonate therapy. So, very common for you to be started on this after a dental check alongside your other myeloma therapy. I generally continue this for at least 2 years, if not longer. But you can consider changing it from monthly infusions to 3 monthly. And we try and reduce steroids because we know steroids cause osteoporosis where possible. And in terms of managing some of the pain that's associated with these lytic lesions or skeletal problems. You can use pain medications if you've got a spot that's particularly bothersome. Sometimes radiotherapy to that site might help. And occasionally vertebroplasty, particularly for those crush fractures that we talked about, can be helpful. So, that's really injecting bone cement into one of those vertebrae to try and stabilize that vertebra, and that improves pain for a significant proportion of people. Steroid side effects. Now, I probably don't need to, mention this in too much detail. I'm sure you all. This is probably the drug that we hear the most about, or the most complaints about, should I say, when it comes to myeloma therapy. Unfortunately, it is really effective myeloma drug, and so it forms part of almost every treatment regimen that we use. But there are a number of side effects that you may experience. Gastrointestinal side effects. We've talked about the blood sugar and blood pressure monitoring that's needed. Mood changes are probably the ones that we kind of hear about the most, and often it's the carers and the family members that notice it rather than the patient. And so again, exercise and physical activity is helpful to try and manage that referral to a psychologist, who you're going to hear from later on in the presentations today. Someone recently referred to psychologists as physiotherapists for the mind. Oops, I think we just missed one. So in terms of steroid side effects, I don't think much else to mention here. Look, one of the other things that I did want to mention is just, cataracts and some of the eye side effects that we mentioned with some of these other drugs. So, if you're running into problems with your eyes, being reviewed by an ophthalmologist is very useful. And in terms of steroids, I think, look, always ask your hematologist about whether you can reduce the dose. If you've been on them for a while and your myeloma is under control, there is that option. And so, don't be afraid of considering that. Steroids and the way we use steroids for myeloma have significantly changed over the last couple of decades. We went from using extremely high doses, 40 milligrams 4 times a week, to 40 milligrams once a week, to 20 milligrams once a week now for some of our regimens. And what we're finding is that over time, we can reduce the dose safely without impacting your myeloma care. I think this slide really I've put in to highlight that when it comes to us trying to treat your myeloma, a holistic approach is really needed. We've got the goals of care, or the treatment goals, to try and control the myeloma, but there's a lot that's going on in your life, and really, treating the myeloma is one aspect of it. We want you to be able to live good lives, get back to living life like you normally would, and that is not unidimensional, and that's where your family, your support networks, the other allied health professionals that you see are going to be critical in helping us improve your quality of life. So partner with the rest of your healthcare team, and again, as I mentioned, you'll have a talk from a psychologist, which is extremely important, and from a financial expert. So that's, again, it takes a toll, right? Being off work, and sometimes the cost of some of the drugs that you're on can have a significant impact. So, that takes a significant toll. So just to summarize, I think people are living longer with myeloma. Our goal is that it really is hopefully turning into a chronic disease. And, one day, hopefully, it's not the myeloma that is going to be the life-limiting factor in a patient's disease journey. Late effects can be related to the disease, but commonly to some of the treatments that you're on. We talked about some of the common side effects that you may encounter, and really that you need a holistic approach to management. And I think nothing sort of highlights that better than this quote from Instagram. Often, in life in general, but particularly when you're dealing with a malignant condition, you can't stop the waves, but you can learn to surf. I think it's really the idea of trying to deal with some of those difficulties, and you don't surf alone. You really need the rest of your team with you. So thank you for listening, and happy to take questions if we have any time.
Thanks, Hasib. Thank you for touching on some pretty tough topics that, people are living with day to day, and really giving an important focus on what people can actually do in a practical way to try and maintain quality of life. I know we're pushed for time, but I do still want to ask a couple of questions. We had quite a lot coming through on the chat while you were talking. So if that's okay with everyone, I'm going to ask a couple. So Emma asked, should she be worried about her low neutrophils? She's been on maintenance lenalidomide for nearly 2 years.
That's a really good question. And I get asked that almost every time I do a clinic post-transplant where patients are on lenalidomide. So the first thing to state is that neutropenia is really common on lenalidomide, and we probably tolerate a lower neutrophil count more so than we would ordinarily whilst you're on lenalidomide therapy. So really it depends on what the actual count is, and what you'll find is, you look on your blood form and you'll see that, oh, my neutrophil count is lower than the normal range. And often that's okay. We've got these sort of magic numbers of 0.5 and 1. Really anything above 1 we're almost always happy with. It really doesn't matter if it's kind of hovering around 1 to 1.5. And sometimes we'll even tolerate anything above 0.5. So it's a tricky balance between trying to keep you on an appropriate dose of the drug for as long as possible to try and make sure we control the myeloma versus ensuring that you're not too at risk to infections. So, what you'll find is your hematologist will drop the dose if it drops too low, and adjust the schedule a bit. Sometimes, I give patients a week break in between sort of those during the month of lenalidomide maintenance and so on. So I think it really depends on the level, and just a slightly lower neutrophil count than the normal range is actually often very tolerated.
Great. Thanks for that. One more quick one. If I don't have any bone lesions, do I still need to be on Zamita?
Absolutely. So, the key thing is that it's designed to prevent skeletal related events. And so we have good data, phase 3 clinical trials that looked at all comers, so all myeloma patients, not just people who had those lytic lesions at diagnosis. And the people that got Zometa, there were lower rates of subsequent new lytic lesions forming and, fractures. And in fact, in some of those studies, we even saw a bit of a survival advantage. So it really highlights that it's a very important part of your therapy. Look, over time, the frequency of those infusions can be adjusted. So, discuss that with your hematologist.
Thank you. That was amazing. If I know there were a lot more questions that came through that we didn't get time to go through because you were covering so many amazing topics. So thank you. But we will respond to those questions in our nurses email. So please, if you can email the nurses email at the end of this session, we will do our best to answer those with Hasib's help. So thank you so much, Hasib, for coming along tonight and presenting. We really appreciate it as always. And I'll let you get on with the rest of your night.
Not a problem. Thank you guys so much. And sorry I went over time.
It's okay. Thank you. So it's my absolute pleasure now to move on to our next speaker and introduce her. Her name is Nicola Beswick. And Nicola is a financial advisor, a mentor and confidant who empowers people to create a financially certain future, free from stress and uncertainty. While studying science at the University of Otago, Nicola realised that she needed to swap the lab coat for a career that involved more human interaction. I like the sound of that. She moved into intellectual property law and drew off her science background to become a patent attorney. When Nicola's father was diagnosed with multiple sclerosis at the age of 55, the experience highlighted the importance of financial education and structure so people can plan for the future and its unexpected hurdles. Nicola said goodbye to her legal career to become a financial planner. In 2019, Nicola became involved at an advisor level in the Pro Bono Financial Advice Network, or PFAN. Now, PFAN specifically provides advice to individuals who have an experience of a health crisis, or they're going through a health crisis. She was subsequently elected as a director in late 2019 and then chair in July 2021. Since entering the world of finance, Nicola has completed the Certified Financial Planner, Accredited Aged Care Professional, and SMSF Specialist Advisor qualifications. And Nicola is also currently undertaking a Masters of Financial Planning. So she's well and truly qualified to present with us tonight. Today, Nicola works with all types of clients in a range of situations, circumstances, and portfolio sizes to ensure they are working towards a life they desire and deserve. So thank you so much for taking the time to join us tonight, Nicola, and talk about the topic of financial security. Your questions answered. Over to you.
You're more than welcome, and thank you so much for that introduction. I always get blown away whenever I hear people read it because I just feel like I do what I do and I love it. But thank you very much for having me today and help give you a little bit of guidance to work through how to take control of your finances, particularly when you're younger and you're not able, well, you're looking at taking some time off work or you're preparing for this. I know that can be really quite challenging. So just get myself, here's a lovely professional picture of me, and Narelle has already covered off all of my qualifications. One of my biggest thing that I think really does qualify me for this job is all thanks to this gentleman here. This is my dad, and as you just heard, he's the reason why I became a financial planner. Diagnosed with multiple sclerosis, he lost essentially his ability to use his right arm, and he went on income protection policy and payout. And so that made me see the benefit of what financial planning and getting the right structures put in place can have for people. But today we're talking about a couple of really key things, and it's all really about where you are at this point in time of your life stage and how that looks from a financial planning perspective. There's some really key building blocks of financial planning, and these at each step are very instrumental in getting right to know exactly where you want to be. We'll then cover off some really key things like getting your cash flow right. Do you have the right kind of protection in place? Or are you able to access some kind of protection, particularly from an insurance perspective? And are there other things that we can look at along your journey of trying to get through what can be sometimes a difficult time? Now, one thing that you'll see for many financial planning firms is this lovely slide here. Everything we do talk about today is very much general. There's lots of different things that people can have within their situation. So make sure that you do get some professional advice, particularly when looking at some of the strategies or ideas that we're covering off today, because you want to make sure that you're doing the right thing for you and it's tailored for your situation and circumstances. So the typical life stage of financial planning, we know that as we get older, the time span of what we want to do changes. Now, just a second, I need to have Okay, just making sure I can see my slides properly while I have this. Okay, so the typical financial planning life stage, as we go through our 20s, 30s, and 40s, we're very much all around accumulating wealth, then moving into the areas of trying to build, building a family, creating wealth, ready for retirement. And to do that, there are a couple of key things that we look at. The first bottom part of this pyramid, and I think this is a really good key way to look at financial planning, is getting your cash flow right, making sure that people's cash flow is working well. Then we add in the safety net there. So insurances, cash buffers, things like that, as we are building into more of that accumulation of wealth over time before we get to that point where we want to draw down and live off our income. Then at the top of the pyramid is that protecting it from an estate planning or legacy perspective. This all sounds really good, doesn't it? But we know that why you're all here today is because you've unfortunately gone through one of those really big unexpected turns that many of us do face when we come through life's journey. I know that you're probably all sitting here going, it's all very well and good for me to do all these things as a normal everyday way of life. But what happens when life takes this really unexpected turn that we're wanting to achieve? You're probably sitting here going, I don't think I can really afford taking time off work. I'm the sole income earner of the family. How do I manage for that? And also, I'm maybe in a position where I'm rushed to take time off. I might not necessarily feel like I'm prepared. We get very concerned about these things. And so that is really what today's about. Getting yourself sorted so we can manage the unexpected turns. Particularly with you all here. You're in this nice little circle area that I've highlighted, probably a little bit more towards the end with the, I don't know how old everyone is listening to this, so it can be variable, but we are very much in that disruptive part from wealth accumulation and taking that turn of events to try and navigate through this time while we're preparing for the rest of our lives financially. If we look at that pyramid again that I worked through, these key areas that I've circled, the cash flow, the protection, and also that accumulation of wealth is probably the key areas from that pyramid that are important to look at. If we get these right, then we get into a position where we can set yourselves up to navigate through a difficult time. So the first thing we really want to look at is cash flow. Money that comes in, money goes out. Do many of us know what we're spending our money on? Generally not. The day-to-day perspective of what we want to do is with anyone, regardless of whether you've been impacted by an illness or not, is understanding where your money goes. And so very much that budgeting word, that big B word that everyone dreads to hear, is a really, really key thing to get sorted. If you know exactly what it is that you've got coming in from an income perspective now or potentially in the future, that can set yourself up from a mental perspective to know exactly what you may be faced with going forward. Likewise with your expenses. If you know exactly where your money's going, you have that power to understand what you may be able to change. You know, a lot of people do have 5 or so different streaming accounts and don't actually use them. Good example to see that piece of paper and those numbers sitting right there in front of you. And then it also gives you that ability to prepare for whatever may throw your way, particularly when it comes to situations that you have to navigate through quite quickly. Can you afford to put a little bit of extra money away to build that cash buffer, that can be completely handy down the track, particularly if you're in a position where you can still work and you're not really impacted too much at the moment, to be able to build that nest egg that you can access as cash. If you've got something like a mortgage that we all know is a huge impact to our day-to-day expenses, making sure that you're on the right rate, can you get a better discount, those kind of things can go a long way to building up and giving you an extra level of income. These really, really key things that when you build them all together can create a buffer within your ordinary income that you've got to enable you to save it going forward. Probably the number one thing, if you can firstly get an idea of where your money is going right now, looking at I generally say 6 months worth of expenses, that gives you a really great idea to know exactly what it is you're spending your money on, and that enables you to then create a better budget that can then help going forward and give you an idea of what you can cut out in terms of trying to save a little bit more. The other thing that's really important, particularly when we look at cash flow, are the other sources of income that you can get, particularly if you're not working or you're unlikely to be working for a period of time. Now, this might not be you right at this stage, but knowing this information and knowing that the support from the government is really useful when replacing or getting that little bit of extra income that you may have lost if you're not able to work. So concession cards are probably the number one thing that are really good with this. The low income healthcare card. Now, this is a card that can help give you discounts on medical or set medical expenses, and is really based or as an assessment on your income, whether that's you as a single or a couple. Getting access to that can really help give you extra income, but then also reduce the expenses of medical care. Well, essentially someone like a loved one, your spouse, your partner, your parents, can they get access to something like the carer's allowance or the carer's payment? So that helps provide extra little bit of relief from an income perspective. If someone's actually taking care of you and you're not able to work, that can go a long way. And that also gives you access to a different type of healthcare card that gives you better discounts, but you do have to meet a little bit more higher criteria or stricter criteria to get access to that. If you're renting, potentially making sure that you've got rent assist, you've got that in, and you are getting the full payment. This might not be now, might be in the future. It very much depends. Then the next one that I've got there is the disability support pension. Now, this is very much for people that are unable to work. Criteria for applying for this is reasonably strict. The Centrelink will go through a check of assessing your medical situation to see if you qualify, and they will also look at your level of income and assets to make sure that you still fit within that assessment from a particular income and asset test threshold. But that can really help if all going well from that assessment, that can help give you an extra level of income to replace what you may have lost during a period of not working, or if you're unable to go back to work for a longer period of time. The other thing that is really quite useful to know, not necessarily access or if you qualified to access right now, is what level of insurances do you have in place? You have different types of insurances there that are accessible, And a lot of them are in that next layer of the pyramid, so that risk protection perspective or that financial safety. So building that cash buffer from excess cash flow that you've got can be really, really useful. But making sure that you're across your situation when it comes to insurances can be worth its weight in gold when you need to have access. So there's 4 key ones there. We've got life, which is a payment when someone passes away, total and permanent disability, a payment for someone that is completely incapacitated and unable to go back to work again. We've got trauma, that is a lump sum payment for specific illnesses that people face. And then income protection, so that's a payment on an ongoing basis for a set period of time and is generally linked to the income that you are earning. Now, you may be looking at me going, I don't necessarily have these insurances, but it's worth having a look. If you do have these insurances, it can help give you that little bit of extra cash flow that you are needing, particularly with someone who may be recently diagnosed or in a position where you will need to take a little bit of time off work, but you're not completely incapacitated. Trauma and income protection can be really, really useful to access and help replace that income and give you that little bit of extra buffer or security financially. One thing that you also want to make sure you do when you're particularly at this point in time is make sure you're protecting your partner, your wife, your spouse, your husband, and your family if you've got a family, and making sure that they have protection from this perspective, from an insurance perspective, is actually a really key thing to consider. Now, it sounds like I'm telling you to take something out and that will cost you more money to take out. But if something happens to them and you're the one looking after, say, a family, or you're the one left, having that security from a financial perspective with insurance taken over that person can actually help ease the burden down the track as well. So even though one of you may be ill and the road ahead is looking quite uncertain from that perspective, making sure that you're covering the other person that exists within your family is really just as important for the future as well. Now, it's good. We've gone through cash flow. We've talked about the different types of things that you could potentially have. But what about where these insurances may exist? You know, a lot of us, we go through we start off, we have our first job, we get a superannuation account opened for us, we contribute to it. And without knowing it, we're building up a little bit of wealth there that is, for its purpose, accessible down the track when we retire. But also attached to that, maybe these insurances that I've just talked about. So particularly life, TPD, and income insurances could potentially be housed within a superannuation account that you currently have, or you may have had and completely forgotten about. Understanding what you have now could be particularly important, because you may not need it right this very second, but you'll be prepared and understanding what your situation is down the track, and you will be able to protect that little bit of wealth and that insurance for when the time is needed. So education and knowledge is key. It's probably one of the second best things from a particularly cash flow perspective. Understanding cash flow, understanding where your financial position is, can really help your situation, and knowing when to access something at the right time is important. We talked about insurance within superannuation, but if things really do get treacherous, what you can do is potentially look at accessing some of the superannuation that you built up. Now, this ordinarily, superannuation is there for people at retirement to help fund for that, but there are times where superannuation can be accessed. Particularly the key things that are important in most likely your age group will be temporary incapacity. So coming back to that income protection type of scenario, you're off work and going to be off for a period of time. Permanent incapacity, so unable to work again. Financial hardship, and also compassionate grounds. So really a couple of key areas that if you really do need that extra little safety net to help you, you can go there. There are strict criteria with each of these. You have to make sure that you do meet various points within superannuation law, but at least it gives you an idea that it isn't this little bucket of money that's locked away until you're old and it is not really useful at this stage right now, particularly when you're going through some health challenges that mean that you can't work. There are things to be aware of though, and this is probably really, really critical things to be aware of. Taking money out of superannuation is good, but it is potential tax consequences there. You don't want to take out extra money and under a way that means that most of it goes away in tax. You have to make sure that that's set up rightly, particularly if you've got access to any of those insurance payments. Also, what you want to do is make sure that you keep any superannuation insurances or insurances linked within superannuation active. There is something that's been put in place recently, or not so recently now, where account balances that are quite low or haven't had any contributions for a period of time mean that they become inactive and they can cancel off those insurances. So being aware of what it is that you've got and maintaining an activity or maintaining those insurances can be really quite useful, but then also a really easy thing to keep up there when you need it at the time. So this is what I've got here on this slide here, is just making sure that any accounts that you have with superannuation they don't become inactive, they don't get lost in the system, and you lose those very important insurances that you could potentially access down the track. I've had personally situations where people have ended up with multiple superannuation accounts and multiple insurances within those accounts, and that has really changed their lives financially. So being on top of that and making sure that you keep those insurances active is important. I think I've made the point there quite a lot, but it is one of those things to be aware of. So what's this all great? A little bit of theory, and how do we look at these situations? What do we want to do with you potentially in your situation? So I've got two case studies. We've got Mary and Gary here. So Mary, she's not working. They have two children, and Gary stepped back from his role and was essentially become Mary's caregiver and helped with the children as well. So what they found was his income dramatically decreased. This really impacted their cash flow. They had a mortgage, they have living costs that kind of weren't quite close to what Gary earned, but with the savings that they had, they could actually get by for a little bit. They had a little bit of superannuation and some insurances within their superannuation accounts. So really useful from what we've just talked about. what happened with this situation is the advisor had a look specifically at the cash flow to make sure that they could manage the debt, particularly on that home loan. As we know, interest rates rising, it's a particularly important thing to get on top of. They looked at the personal insurances, not only for Mary and to have a look at what they could access, but also what Gary was covered for, particularly when they have 2 children, that he was the primary income earner for in the family. They looked at the superannuation and then also looked at Centrelink to see what type of government support they could get, and then also looked at what they could do with the cash savings and what other considerations were really important within this. So without going into too much of the specific details from a numbers perspective, getting insurance paid out for Mary really helped with getting a lump sum which they could then put towards their mortgage. This meant that the cash flow or the income that Gary was earning was more than enough to help them get through their day-to-day expenses without actually having a burden of that mortgage. A little bit of government support. Now, because of the amount that Gary was earning at the time, they could only get the low-income healthcare card. So still very important from a medical perspective. That gives you a nice summary as to what happened with their situation and how things progressed with them. But then we look at someone on the other end of the spectrum. Mike is 27, lives in a share house, hasn't worked for a period of time, and his only income was the government support. And in this case, it was the job seeker, and had a number of superannuation accounts all just kind of littered around. He didn't have any debt, which was also a good thing. So it meant that his income from the job seeker was essentially there to cover his cost of living. With financial advice, and particularly with things that they looked at, was firstly coming back to that cash flow management. With Mike, he went from being able to get the job seeker to the disability support pension, and that increased the level of income that he was receiving. There's quite a difference between the two, so having that government support really did increase his level of cash flow coming in to get him through. Also rent assist, so getting a little bit of support to assist with the rent that he was paying. That was a really key thing to help increase the cash flow. He also managed to get a really good grasp of superannuation. So each individual account, he knew exactly how much was in there and what insurances were linked, particularly when someone who hasn't been working, income protection may not be there, but that total and permanent disability insurance could be accessible for him and give him a lump sum to help him when he needed it the most. So that is the benefit of getting across what your situation is and how much you've got to have up your sleeve when various situations arise. What is something else that's really important to consider when you're in this situation? And that's estate planning. Now, this is one topic that not a lot of people love talking about, but it's making sure that you have specific documents in place to help people, particularly loved ones, give direction to the team around you when you're unable to do so. So wills give someone, wills essentially come into effect when you pass away. So they will set out your assets, and particularly superannuation. That's a key thing to get checked to make sure you've got a cover there. but distributes based on how you want that to happen. So if you want specific amount to go to someone, it's sorted out within the will. Power of attorneys. Now, power of attorneys are really important because these come into effect when you're incapacitated and unable to make decisions. So financial, medical, and also general health directives and things that you want to happen when you are incapacitated. This gives the authority to your nominated person the ability to make those decisions on your behalf. Too many times that we've seen, I've particularly seen cases that have to go through the tribunal, and I'm here in Melbourne, so it's the what we call VCAT, so Victorian, actually don't know the acronym, what it stands for, but it's a long drawn out process, and we'll make sure that or essentially it doesn't help people at all. People, it's long drawn out process. It you have to have a loved one to be able to say, yes, this is what I have to do. And if they have to make decisions, generally that has to then get signed off by that authoritative power before you do anything. So having that power of attorney in place can go through, can save your loved ones that grief of trying to get that situation sorted and not have to deal with bureaucracy at the time that's the most challenging. Helpful tips. So I was glad to see one of my most helpful tips that I had that's at the end was also within the previous presenter's side. But what I'll do is jump to a couple of key things here. Firstly, just make sure that you get a really clear understanding of your situation. Where are you right now? Where are you going? What's the long term looking like? Work out a budget. Make sure you know what is coming in, what's going out, and what can you access now. Is it Centrelink? Is it insurance payments? Understanding all those key things can really give you the ability to understand what you may get now and in the future. But then also make sure that you're working through other key things like building up a savings, planning for that future, and making sure that those insurances, again, you're cross with, because then that way you know exactly what it is that you can have down the track. Finally, as was highlighted earlier, building that team is really, really important. If you've got the right people around you that can really help with support, not necessarily just financial or medical, but family, friends, those people within your network and your support team are really, really important at this stage. And each person will play their own individual part in getting this, getting you through whatever you're going through now or in the future. So any questions?
That was so great. I got a lot out of that, actually. So thank you very much for sharing it. We do have one question, which you kind of touched on when you were discussing your case studies, and it did come through before you talked about those, but I'm still going to ask you in case you have any additional tips to add. So Chris has asked in the live chat, he's got an upcoming stem cell transplant, which is going to take him out of commission for a few weeks. He doesn't have private health cover. His super fund has told him that they won't cover him with any sort of income protection. So what should he do? Who should he talk to?
Oh, gosh.
Nice, easy one for you.
Nice, easy one. Give me a call. I think is probably the answer to that. I think there's so much in there, and it is such the options very much do depend on your situation. And even though there was the general kind of, these are all the things that you can do. What you can actually access with your situation is very specific. So that would be my advice.
Thank you for giving a good answer to a hairy question. So I'm sure that Chris will probably take you up on that and seek some advice, which is a good idea. Thank you so much, Nicola. You have shared some really important information and some tips and touched on some really important things to do with financial security. So thank you for giving us your time this evening. And I'm going to let you get on with the rest of your night. So thanks. So I want to acknowledge that we are, of course, running a bit over time, and I hope you can all stick around for our final presentation. Our final presentation is actually by someone who has presented for us in our National Myeloma Month series. But she was so exceptional that we invited her to give us another presentation, which is more in keeping with the younger population of myeloma sufferers in the community. And that is Dr. Veronica Johnston. So she is a clinical psychologist at the Bacchus Marsh, Ballarat and Greater Geelong psychology clinics with over 20 years experience working in schools, hospitals and private practice settings. She adopts a compassionate, collaborative and engaging approach to therapy. This approach allows for a strong connection with her clients, emphasising a space of openness and trust. She works with her clients and their loved ones to assess the problems they are facing, to implement individualised, evidence-based treatment plans that encourage her clients to live a more fulfilling and meaningful life. After a personal experience herself with loss, Veronica's passion grew for working with people in the midst of traumatic life events and those experiencing grief and loss. She has confidence and belief in an individual's capacity to find purpose in the midst of increased distress when faced with the things they can't change. Now, Veronica has actually pre-recorded her presentation with us this evening as she's away on a well-deserved break, which we can all understand and need. She is more than happy to answer your questions, though, when she comes back from her leave. So please still send them through, but send them through to our nurses' email address. So I'll tell you that again, and we'll put it in the live chat. It's nurses@myeloma.org.au, and we will get back to you. So now sit back and enjoy this final presentation of our seminar tonight from Veronica on adapting to changing relationships.
Hi, everyone. I'm Veronica Johnston. I'm a clinical psychologist working across 3 different clinics in Victoria. So Bacchus Marsh Psychology Clinic, Greater Geelong Psychology Clinic, and Ballarat Psychology Clinic. Thank you for having me today, and apologies that I can't be there in person, so our presentation can be more interactive. But from my understanding is that the girls will gather some questions at the end if you've got any, and you can send them through to me, and I'll do my best to email you back or disseminate some information that's helpful. Today, we're going to be talking about maintaining healthy relationships while living with a chronic illness. I presented at a webinar a few weeks back now around some similar topics to what we're going to talk about today. So I'm not sure if some of you were in attendance at the last webinar or have watched that. There'll be slight, I guess, commonalities in some of the information that was presented then and what I'm talking about today. But we'll definitely sort of dive a little bit deeper and have a real focus on healthy relationships and how they're impacted. So some of the things we're going to cover today is we'll start off by looking at changes to our own identity after diagnosis and living with an illness. And then we'll look at how those changes to ourselves have to impact the changes to the relationships around us and our loved ones, and also touch on at the end how we can talk to children about this really difficult topic. So we know that trying to integrate the idea of living with a chronic illness into your identity is a really difficult process. And it's a process that requires time, a lot of self-care, and a lot of patience. And this process of trying to come to terms with, accepting something in our life that we can't change is relevant to not only the person that's living with the illness, but also their loved ones. This really changes how we view ourselves, trying to come to terms with this. And the way we view ourselves is really important because it impacts the way we interact with other people, and it impacts the way we interact in the world. It can also change the way that other people interact with us, making relationships that we've known sometimes quite difficult, and navigating those changes together and building those support networks is really important. So today we're going to have a look at, sort of what formed your identity pre-diagnosis, how you saw yourself, what sort of attributes you might have had, and then what changes have happened since then. How do you now make sense of who you are? Often when we come across these things in our life, we feel a huge sense of loss. Our values change, and that's okay. What's important to us changes. Along with other things, changes to yourself undoubtedly impact relationships with people around you. I'd like today to be, despite me not being there in person with you, I'd like today to be a little bit interactive. And the next slide, I'm going to ask you to do a few things for me so you can start to understand and come to terms with some of the weight of the change to your identity that might have happened, and some of the losses that you might feel. These exercises, I'm going to give you a short amount of time to do these exercises as a part of today, but I really encourage you to revisit this and take a little bit more time with it if you feel like it's something that's important to you and is really relevant to you at wherever you're at now. And because it might just be that this uncovers some things that are really enlightening for you around where you might want to do some more work in terms of your mental health and healing. So these exercises are relevant to the person living with the illness. It's also relevant to people who are carers or are loved ones. So despite your role at the moment, I'd like you to have a go at these exercises. So I'm just going to set a timer for 1 minute. If you've got pen and paper there, even the notes on your phone, or you might even just want to think about it. We're going to do one at a time. So I'd like for you, just grab my timer. For the first minute, I'd like you to think back to who you were before your illness, or before your loved one's illness, if you're a carer or a family member. I want you to spend a minute just writing a list of the words that you would have used to describe yourself before your illness. Okay, so I'm just going to set the timer for a minute, see how you go. Okay. So if you need a little bit more time, so you can revisit this later. I know I'm not giving you lots and lots of time to delve into this, but just getting a bit of a taster due to the time pressures of the session. But now I'd like you to try and clear your mind from that. Take a big breath. And I want you to write, in this next minute, I want you to write a list of words that you would use to describe yourself now. So thinking to right now in this sort of present moment, over the last couple of weeks, what words would you use to describe yourself? So we can get a sense of some of the changes to how you view yourself. So I'll set the timer. Okay. We have the rooster in the background. Sorry, that's out of my control. So we're just going to have to go with that. I want you to have a think about the following questions. What changes have happened for you since your diagnosis or your loved one's diagnosis? So I want you to think in these sort of different areas. Some may be more relevant than others, but I just want you to jot down, like, what changes have happened for you in your body? If sort of physical changes to your body's capacity, to the health of your body. Just write a few things down about the changes that have happened. I want you to also think about what changes have happened in your relationships since your diagnosis. What changes have happened for work? Have there been any changes in your work? Maybe there's changes in your income and finances due to work changes, or health expenses, medical expenses that have come up, the capacity to work or the role that you're doing, other people around you's work. There's been some changes for you in your interests, in how you spend your time, what does a day look like now compared to what it used to look like? So spend a little bit of time reflecting on those things, writing these things down, really fleshing out who you are now and what does life look like and how's that different to what it used to look like. None of this has been within your control. It's happening to you, and this change is happening, and there's nothing we can do about it. So these things that we're reflecting on here, they've come about due to an illness and something that you have to front up to. And it requires considerable change. And a lot of that change is really hard to deal with. So I want you to think about which parts of yourself you might have lost due to your illness or your loved one's illness. Which parts of yourself have you lost? So thinking about relationship, elements of relationships, elements of your work, your interests, your day-to-day, your body. Just write a big list, think about it. And I'm going to keep moving on with the presentation, but I want you to continue to revisit this and hold all of this in your mind while we go through the next few slides. Whenever we think about these big changes in our life, there's loss. And there's 5 stages that we tend to experience when we're losing things. And it's really natural to move between and around all of the following. Typically, some of you might know these as like the stages of grief, and that's what we are. We're grieving parts of ourselves. We're grieving things, who we knew about ourselves, and changes to our identity. So these things become really prevalent. We might experience times of denial, just not even thinking that this is happening, this can't be real. We might have times where we bargain with things. What if I had have done that? What if we had have done this? What if this happened? Would things be different? How could I have changed this? Lots of questions, lots of thinking about what we could have done differently, trying to work out how this has come about and how it might not have been able to come about. Like, could I have done something? We might be angry at the world, angry at, the doctors, angry at the system, angry at lots of different things. We might hold anger at cancer. We might feel depressed. We might feel, this huge, heavy sadness about some aspects of what we've lost. And then there might be other things that we're feeling accepting of, that we can sort of accept that this is happening. When you look back over your list of the things that you've lost due to your diagnosis, due to living with this illness, I want you to think about which stage or which emotions you're currently feeling about each of these things. For instance, if you've had to have changes to your finances or work situation, where are you at with that? Is there an acceptance that this has to happen to focus on my health, and to try and allow my body to heal? Or are we angry about this? Or are we sad? Or is that something that we haven't really touched on yet and we're in denial about it? Think about all of the different things and the different parts of your journey and which stage you're sitting in, because there's uncomfortable and distressing feelings. And then there's also levels of acceptance. And sometimes where we're feeling those distressing feelings, these are the parts of it that we're still grappling with and finding really difficult. And that's sometimes where we need to focus and communicate and allow space for the emotions that are there. I talked in my last presentations, this might be a double up, but about holding a ball under water. You try and hold the ball under the water and you focus on it, and at some point it's going to come up. And it's the same with our emotions. So if we don't allow the ball to sort of float on the water, is that ball can come up, and it can come up quite violently, and we can start expressing these feelings towards people around us, and sort of transferring those feelings onto things that are more tangible. So like onto our partner or onto our kids or onto our workmate or a colleague or our parents. And we can start focusing these emotions into those places because these people exist, rather than really trying to express them and think, well, what am I feeling angry about? What am I feeling depressed about? Really interesting, I think, after this presentation, to sort of you and your loved ones or people around you to do these exercises together and then compare what your feelings are about all of this. Allow space for this communication about emotions and our experiences and how that's changed. If we think about ourselves in relationships, if we think about like a circle, and this might be us, and this might be our partner, and then this is our relationship. Whenever there's changes to one person within that relationship, there's going to be changes to the relationship overall. Just as if there was changes to the relationship, there'd be changes to the people within it. So it makes sense that when there's something really big happening to one of us, at least, that the relationship's going to change and needing to change, as are our roles in it. Now, when we start thinking about families and why, like the more people, the more circles, the more relationships, the more people, the more complicated it's going to get to try and navigate relationships and healthy communication and allow space for these difficult emotions, because there's so many people sort of being impacted and relationships changing. This is not an easy thing. If we think again about those circles as people, I want to show you sort of 3 versions of relationships that we think about. So if we've got this sort of relationship here, we think of this as sort of a healthy relationship. Each person's got their own sense of self, their own hobbies, their own interests, their own sort of self-worth and identity, and they're allowing themselves to like emotionally and physically connect with somebody else, but still maintaining a sense of self. And this relationship is where we would think of being quite a healthy relationship. Now, one other type of relationship we have is where we start to sort of mesh and depend on each other a lot. And we sort of, our circles go like this. So you can see that we lose a bit of ourself by doing this sometimes, but we're really connected to each other. And often these sorts of, there's a need for this sort of relationship when one person is physically unwell, mentally unwell, having a really difficult time, or just not able to manage in the world as easily. So think of a mother and a baby, for instance. And so then, you know, in time, it might move back as the person heals to be more of a healthy sort of relationship. But we can move around. It doesn't just stay as one or the other. And then we've got this other one where we're sort of like this. And this is where we have very big sense of self, but we don't allow ourselves to emotionally or physically connect with another person. So we can be quite, you know, sort of fiercely independent, but really, we're really protecting ourselves. There's something stopping us there from allowing that other person to be in. And sometimes we can jump between those. Sort of pushing people away because we don't want to hurt them, and then bringing them in really closely. And we can sort of get into some difficult relationship dynamics, which, you know, if you sort of reflect on your own situations now with people around you, you know, are there people since your illness and your diagnosis that have become this? Are there people that we've done this to? Are there people that we do a bit of both? And are there people that are like this with us? So how can we, when we're faced with this illness that we can't change, how can we emotionally connect? And how can we keep some of our individual interests as well while we're trying to support each other and just be noticing where we're at? Some of the things we need to be able to do is allow space for difficult emotions, as I mentioned before, like those 5 stages that come up. Where can we have these emotions? How can we healthily express these emotions and have space for that in our relationships? And also recognize when there's a need for space and time away from each other and time in our own sort of pursuits, and honest communication. So they're the key. I'll briefly go over the circle of control again, but this is a diagram that I displayed last time, where we're talking about there's things that are completely within our control, and then there's things that are outside of our control. And when there's so much happening to us that's out of our control, we try to control everything. And sometimes that means we try to control other people's emotions and behaviors. And we do that by adjusting our own emotions and behaviors around other people to, you know, because we don't want to impact them too much, or we don't want them to feel a certain way, or we don't want to be too much of a burden on that person. So we try and do these things to mean that the other person acts differently or has a different experience, but ultimately we can't control this. And when we're really stuck outside of that circle in these things that we can't control, it's really distressing. And it often means that we assume what our loved ones want or need from us, And it can lead to gaps in communication and really sometimes increased feelings of disconnect, loneliness, and misunderstandings. And we can be left feeling quite invalidated. So we want to step back into the circle and focus on things that are within our control. And I guess be curious to our loved ones' emotions. And we'll talk about that now. So effective communication is, as I said, we don't want to assume what someone else is feeling or how someone else will feel. Instead, we want to be curious. We want to ask questions, ask people what they need. If I was feeling a certain way, would you want to know about that? If I was needing space, how could I tell you that? Have open discussions about this. Actively listen to what your loved one's saying. Sometimes these assumptions that we have actually become a barrier to us gathering information from the other person. Show empathy. Sit with the difficult emotions. Don't try and change them. Don't try and take away someone else's distress. Sit with them. We want to, the footprints in the sand, we want to walk alongside someone in their journey and the difficult emotions, not necessarily pick them up and carry them. We want to sit with them and listen and be curious. And I'll talk about some emotion coaching when we get to talking to children. Use I statements to express yourself. I feel. It's much less threatening and much more, it leads to a much easier conversation. Express your needs in a productive way. I'm going to show you a way to do that in a second as well with a technique we call Dear Man. And take a breath before responding. Like the power of one breath is pretty magical. Even just do it now. Just notice how that feels and then speak. Shift your emotional experience before communicating. If you need time away, do it. Sometimes we work with clients and we get them to come up with like a circuit breaker word, something that's silly, like pineapple. And that word we can use, and we can agree to use it when things are becoming heated, when there's hugely high emotions, and sort of that's maybe something that you might bring in around any sort of anger or unhelpful arguments that can sometimes come about. So when we're trying to express our needs, we use a skill called Dear Man. And so it stands for describing, use clear and concrete terms to describe what's happening for you. Use the facts only. No opinions, just the facts. And I'll show you an example in a second. Express how the situation makes you feel. Don't expect others to read your mind. Don't expect them to assume. Then assert what you're wanting or needing and reinforce how that's going to help you if that happens. Now, be mindful of your objective when communicating and be willing to negotiate if the other person isn't able to give you what you need. An example might look like, we haven't had dinner as a family for 4 weeks. I feel more distant from everyone and miss sharing this with you all. I'd like for us to have dinner together at least once per week. If we could do this and prioritize it, it'd bring me a lot of joy. The Dear Man skill is a really effective way of communicating our needs. Have a look it up. I'll send some resources to the girls to be able to disseminate it to you. But try it out. It can be really powerful. Lastly, and I know I'm getting close to time, but lastly, I wanted to just touch on how we talk to kids about the uncertainty and your illness. There's no exact answer to this. Developmentally, it can change a lot from how old the child is, the intellect of the child, the emotional intelligence of the child, but we try to use developmentally appropriate language. And you might even allow them sort of space you might do some drawing or write their worries and express their worries out about, as you're talking. But what I know is that children are really good at picking up on things, and sometimes we actually don't give them enough credit for what they're noticing. They're noticing the nonverbal cues that we're giving them. We naturally try and protect them from difficult things. We don't want to upset them, but it isn't always the best way because they're noticing, they've got the ball. And if we're not allowing space for them to talk about their feelings, about this, then they're holding their ball under the water. And at some point, we're going to see that with changes in their behavior. Notice their emotional responses, what changes are happening for them, their sense of loss. They're having the same experiences that we are. What feelings are they expressing? What feelings are they showing you? Often we see anger, we see changes to behavior, changes to appetite, changes to sleep routines. These changes to behavior are telling us they've got some really big feelings. Think about what stages they might be in. Think about what their expressions of anger or upset or withdrawing, what are they actually feeling under there? Often a lot of worry and fear and lack of control and uncertainty. So having conversations with them can provide some level of certainty and give them a sense that they're connected within this and they can talk to you about it. Notice what's happening with them. Are they wanting to connect with you more? Do they become overly responsible and try and protect you? Or do they sort of push you away a bit? They're going to go through the same things as us. Use the effective communication skills with them. Allow space for these big emotions. Allow space for questions and become a really good emotion coach. When kids are displaying big emotions, even when adults are, it's a teaching moment. Help the child develop language to express what they're feeling by labeling it, being curious to it. I notice you're crying. I wonder if you're feeling really sad. Or I notice you're not sleeping really well. I wonder if you're feeling really worried for mum. Validate it. Show that you understand and that their feeling is normal. You know, I feel really sad when I think about it too. It's really normal to feel that way. And lastly, try and collaborate with them to find a solution. I wonder what we could do in these moments to make them feel easier. Maybe we can do some things together. Sometimes I like to grab a pillow, hug it really tight. Sometimes I like to put on music, or I like to draw or write my feelings. Try and problem solve together, brainstorm together. I know I've raced through those last few skills, but look them up. Ask questions about it, as I'll try and provide some links and resources. But this information is really readily available on the internet. We've got clinics at 3 different locations: Bacchus Marsh, Geelong and Ballarat. We also offer sessions via telehealth. If it is something that you're wanting to talk about more, we have psychologists that are really wonderful in this area and can help you with your interpersonal relationships, allowing space for emotions, sort of problem solving some of these things that come up. Thank you so much for listening. I hope there's been something from today that's been helpful for you, and that you can take with you back out into the world and try and apply or reflect on. But yeah, feel free to get in touch with me through any of these avenues.
Okay, I think you will agree that was a fantastic presentation from Veronica, and I hope you all got something out of it. A reminder that you can send through any questions for Veronica or any other questions which we may not have got to this evening via our nurses' email, nurses@myeloma.org.au. If anything this evening has come up and worried you, or you feel like you need some extra support, please call our nurse support line, which is available business hours Monday to Friday, 1800-693-566. We'll also be scheduling a follow-up younger person's online support group early next month as a way for you to openly discuss any of the themes from tonight or any other issues which might come up. You will receive an invitation via email for that shortly, so please look out for that. And just another gentle reminder to please complete our evaluation survey via the link at the bottom of this webpage so that we can tailor ongoing seminars to your needs. That brings us to the end of our seminar this evening. We're very glad that you could join us, and we hope you found it informative and empowering. We express our heartfelt thanks to all of our speakers, to our sponsors, the seminar team at Myeloma Australia, and to the Global Myeloma Action Network for their support. Also, a huge thank you to Patrick and Darren and the team at CVP for their hard work and skill in production. Thanks again for joining us, and good evening to you all. See you later.